Three, two, one. You can start now.
Very good evening to all and good morning to you, Shaji sir. I welcome you all and thank you all for joining. Today we have the 21st session of Innovations in Hematology, and the topic of discussion is high risk and ultra high risk myeloma. So we are privileged to have you, sir, Dr. Shaji sir, as the guest speaker today from Mayo Clinic, who needs no introduction and whose work has deeply influenced the myeloma field, with Dr. Rahul Bhargav sir as the host, and I will be moderating the panel. So, why this conversation now? So, it started with us having two relapsed refractory multiple myeloma patients in our OPD on the same day with translocation 11-14, one with a biochemical relapse and second with an extramedullary disease. I remember putting that on X and mailing to sir, and sir replying how to go about it, and that's how this thought of this talk came, and that is why we are having this conversation today now. So agenda is simple. It is displayed on the screen. We'll keep this tightly structured. And I had posted on various platforms regarding questions, and I have tried to put those together, and we will discuss with you at the end of the discussion. Also, if anybody has any questions, any cases to discuss, they can put in the chat box and we'll club and discuss later as after the talk. So I'll stop sharing my screen and over to you, sir.
Thank you, Meg. Let me try and share my screen. Is that visible?
Yes, sir.
Okay, perfect. All right. Thank you, Rahul. Thank you, Meg, for this morning for this talk opportunity. And what I'm going to try and do is, spend, as Meg said, maybe the 30 minutes or so just going through some of the data supporting how we identify these individuals with high-risk multiple myeloma and the evolving approach to this. Again, there's really no true right or wrong, but it's all relative depending on the context of the patient's clinical behavior and the access to different therapies. So how we treat myeloma obviously has evolved over time, but some of the fundamental concepts have remained same. In patients with newly diagnosed disease, we give them an induction therapy, consolidation, and maintenance. The intensity of the therapy and the duration of maintenance, often depending on the underlying disease risk characteristics and other host characteristics as well. Those who are eligible for a stem cell transplant gets transplant as consolidation. For others, you continue with the same therapy. Even though with the novel therapies, increasing number of patients are continuing in their first remission for much longer than they used to in the past, majority of the patients in the current practice still relapse, and we have to think about how to treat them. And when you think about outcomes of myeloma, even though it's one disease, there's significant heterogeneity in the clinical outcome of these patients. Even when we look at those more recent data, for example, on the left-hand side, the triplet induction transplant from the IFM trial, or the MAIA study on the right-hand side in the transplant ineligible patient population getting daratumumab lenalidomide, you can see that there's still a proportion of patients who relapse very early within 2 years of diagnosis, despite these effective therapies. The patients whom we often think about as having ultra high risk, whichever way you define it. And then the patients who can maybe relapse maybe within 4 years, maybe we can think about even them as high risk, given that the median survival with these regimens are often in excess of 6 to 8 years. So the question then is, how do we identify the high-risk patients, right? So there are the question, so the other important question is, why should we even bother identifying them? So here we can see what we do today in the clinic, right? So we see the patients with myeloma. We know this high-risk patient survival is decreased. There's patients with intermediate risk. Survival is in between the standard risk and the high-risk patients. Where we want to get to in the future is that we can actually treat them with 3 different types of treatments, leading to similar outcomes, in a way negating the impact of these risk characteristics on the patient outcome. So in order to do that, there are 2 things we need to understand. One is what determines the outcome so that we can identify the patients with the poor outcomes. Second, we need to understand the biology behind it. Why do they behave the way they behave? And third, can we actually adapt our treatment to match the biology so that their outcomes eventually become quite similar? So in terms of the factors that determine outcomes, clearly the most important ones, or at least the ones that can be measured objectively best, are the plasma cell clone related characteristics. Like the genetic abnormalities, we know there are a set of fish abnormalities and others. The serum LDH levels, presence of circulating myeloma cells, presence of extramedullary disease, how fast these myeloma cells proliferate. There are host-related factors, age, performance status, and comorbidities, which we can't really often change, but we can adapt our therapies to match that. And there are certain things that determines or that reflects the interaction between the host and the tumor. A good example of that being the international staging system, immune parameters in these patients, as well as renal function, among others. So amongst all these, probably the most important factor are the genetic abnormalities we see in this disease. And broadly, we can categorize them into primary abnormalities and secondary abnormalities. The primary abnormalities are kind of the large structural abnormalities that are translocations and trisomies. And the translocations typically involve the immunoglobulin heavy chain locus that is brought in proximity to another gene that then drives it. And there are trisomies, which are often odd-numbered chromosomes. And obviously, these are not a strict separation because there's about 10% of patients who can have both. But the trisomies are often driven by MYC dysregulation, whereas the IgA translocations are often driven by the cyclin D dysregulation. But these are not the only abnormalities. These are the ones we think are present from the beginning, but these myeloma cells can continue to acquire new abnormalities, which includes monosomies, deletions, amplifications, as well as point mutations in specific genes, about a dozen of them. So even within these abnormalities, we think about chromosome 14 translocations being a high-risk abnormality. There is heterogeneity even within them. Depending upon whether there's, again, NSD disruption, there's a node disruption, early or late disruption, there can be heterogeneity within the 414 translocation. And you've probably seen this in the clinic, that some of your 414 patients are doing very well, while others have a really bad outcome. But it's also the presence of just the primary abnormalities is what else goes with the primary abnormalities. So one of the best examples is the chromosome 17p deletion, which is present on the, again, or the TP53 gene that is present on the short arm of chromosome 17. And you can see that when you have a deletion, then your outcomes are poor. And if you have mutation of the remaining allele, then your outcomes are even worse. What about other kind of secondary abnormalities? One of them is chromosome 1. Again, you can actually have gain of chromosome 1, which is one copy more, or you can have multiple copies, which we often call as amplification. And you can see the outcomes are worse when you have chromosome 1 abnormalities, with some suggestion that the amplification might be worse than 1. Similarly, you can see deletion of 1p. If you have one deletion, monoallelic deletion versus biallelic deletion, the outcomes are really bad. So what it really tells us is that the multiple genetic abnormalities, all of which have some impact, but the important thing to remember is these things do not always go individually, they often go in combinations, and that has played an important role in the recent definition of high-risk multiple myeloma. So the incorporation of genetics into the staging system started with the revised ISS staging system back in 2015, when the presence of 17, B14, 16, or 414 was added to the ISS staging system. Again, 3 groups with very different outcomes. But this was obviously insufficient as we learned more about the genetic abnormalities. And that led to some additional risk stratification system, like the Mayo additive staging system, that again showed the impact of presence of multiple abnormalities. And the same thing was adopted for the second iteration of the revised international staging system, where multiple high-risk abnormalities like the ISS stage 3, 17p deletion, LDH, 414, 1q, all were given some weight, and 4 groups were developed that with very different outcomes. So finally, there was an effort last year, 2 years ago, to bring together all these different findings and see if we can develop a consensus genomic risk stratification system So came up with the IMS-IMWG consensus risk stratification system, where you had to have two different abnormalities in order to call a patient as having high risk, unless you had a biallelic 1p or a presence of 17p deletion of T53 mutation, or a beta 2M with more than 5.5 with normal renal function. So either one of these abnormalities or two of the other abnormalities on the right-hand side would make the patient as high risk. And this pertains to about 20 to 25% of the patients with myeloma that we see. Now, there is obviously some things that are not covered by the current genomic risk stratification system. So you have to keep in mind that there can be point mutations, for example, mutations in the DNA repair pathway, RAS mutations, all of which can have impact on the outcomes of patients. There are gene expression-based classifications. This is the RNA expression. There are multiple signatures that have been developed that reflects the biology, and believe that this is something that can add to the current stratification, but difficult to implement in the clinic because of the difficulty in doing RNA sequencing in a timely fashion. One of the things that is increasingly taken kind of come to the forefront and has been known for almost 3 decades is the presence of circulating plasma cells. And we know the more the circulating plasma cells, the worse is the outcome for patients with myeloma. And in general, when you see myeloma cells outside of the bone marrow microenvironment, that generally denotes that the myeloma cells have become quite independent of the microenvironment, have become more proliferative, they have a different metabolic machinery. All of this leads to escape of the disease outside the bone marrow, which can be either circulating plasma cells, if it's extreme, then it's plasma cell leukemia, or you can have extramedullary disease, which is soft tissue disease outside of the marrow, which can also portend a poor outcome, whether it's seen in newly diagnosed patients or relapsed patients. So when you put it all together, you realize that this is a spectrum of risk, right? Patients can have 1, 2, 3, 4, multiple different high-risk features. And the important thing to remember is none of them are absolutely independent. They all tend to go hand in hand. So there's interaction between the different abnormalities. But we can group patients broadly into 3 groups, standard risk, high risk, or people with extremely high risk disease, which usually happens in the presence of multiple genetic abnormalities, circulating plasma cells, or extramedullary disease. So we talked about what determines outcome at the time of diagnosis, but that does not, the risk stratification in myeloma does not stop there. It continues depending upon how the patients respond to therapy, how deep a response they get, and what duration of response do they get. We know that the patients who are refractory to that initial therapy usually have very poor outcomes. These are patients called primary refractory who never respond to any therapy. Their outcomes are poor, as you can see from this study. The deeper the response, the better is the outcome. This has been shown multiple times, and we know that patients who are MRD negative can have better outcomes both in terms of PFS and overall survival. And finally, how long the response lasts is equally important. You can see here, patients with an early relapse has a very poor outcome, even if they were standard risk at time of diagnosis. So this highlights the importance of continuing to risk stratify or prognosticate patients as they go through therapy. You can see here that patients who relapse early, even with a standard risk at baseline, has poor outcome compared to patients who may have had high risk abnormalities but don't relapse or have a very long response. So there's a functional aspect to that disease risk that is often difficult to determine at baseline. Then finally, there are certain things that we can necessarily change, but we can adapt therapy to it. Which one is age? We know the older the patients are, less well they do. Some of it is just the comorbidities that goes with it. Some of it is the expected lifespan. The performance status is an important characteristic. Again, poorer the performance status, earlier the mortality or higher the mortality. And some of it is related to disease and can improve once you have the disease under control. You see the same thing with frailty. And the more the frailer the patients are, the worse their outcomes are as well. So then the question is, okay, so now we have a sense of, okay, what are the reasons behind behind the difference in outcomes we see amongst these patients, and to some extent, what drives them? Now the important question is, can we actually adapt our therapy to that? So we already talked about understanding the differences and need to understand the drivers of heterogeneity. Now what we need is, do we have interventions that can differentially affect the outcomes? That's where the individualization or personalization of medicine comes in. You know, increasingly, it's not just myeloma, cancer and outside cancer, we are starting to do more and more of it. Obviously, one thing is anybody who comes in with myeloma, we give them the same treatment. That is like a one size fits all. But as we already talked about, we know there's heterogeneity and there's opportunity for us to alter the therapy based on the risk. Now, that is still stratified medicine because we are just broadly telling them you're high risk, you're intermediate risk, you're standard risk. But what we really in the future at some point want to do is personalization, that even within this strata, can we actually adapt therapy based on some individual abnormalities? And I think we are still not there, but we are hopefully getting there. So let's talk about how we can individualize treatments, right? So the stratified approach is what we use most commonly, which is a specific type of treatment approach, transplant versus no transplant, tandem versus single transplant. Or can we target a particular level of response? We want to achieve MRD negativity to the level of -5 or -6. And you can vary the duration of therapy, treatment till progression, or treatment for a year, treatment for 2 years. So these are all stratified approaches. Anybody with high risk or anybody with intermediate risk, you might take one approach versus the other. But using a specific type of drug is more closer to what you would want to do for a precision-based approach. So let's think about the stratified approaches, right? One is to intensify the initial treatment, and this is the tactic that was taken for the Optimum trial in UK, where they gave a 5-drug induction transplant, 4-drug consolidation, then 3-drug consolidation for a year, and then 2-drug maintenance till progression. So start intense, continue intense therapy. People have looked at 2 transplants versus 1 transplant. The data is pretty soft. I think we have pretty much stopped doing this tandem transplants in patients. There are other studies that have looked at tandem transplant. This is another French study that looked at high-risk patients with multiple myeloma, quadruplet induction transplant, quadruplet consolidation transplant, and then maintenance with 2-drug. The data looks pretty good. Deep responses, durability seems to be decent. But again, these are all different small, single-arm studies that are exploring different approaches. So the whole concept of using 2 drugs instead of 1 for maintenance has been looked at in a variety of retrospective and prospective studies. We know that lenalidomide single agent is considered standard of care, but we also know from those studies that that's probably insufficient for patients with high-risk disease. So here's a study that looked at bortezomib lenalidomide as maintenance. Here's the Forte trial that looked at carfilzomib len as maintenance, comparing it to len. And it seems to improve the progression-free survival in all these subgroups of patients, including a variety of different high-risk abnormalities. The other high-risk patients that we often think about is the patients with extramedullary disease. And this is a study that we did in patients with true extramedullary disease, not just disease breaking through the bone, but rather disease that is truly independent of the bone marrow in the soft tissue. We treated them with a combination of 2 different bispecific antibodies, so teclistamab targeting BCMA and talquetamab that's targeting GPRC5D. And you can see that in this difficult to treat patient population, nearly 80% of these patients actually responded, 70% VGPR rate, 55% CR rate. And these treatments actually were much better than using either of the bispecific antibodies individually. And we know that, at least they have 2/3 of these patients remained free of progression a year from start of treatment, which was obviously, rather uncommon in patients with extramedullary disease. So here's another approach to taking a disease characteristic and applying a treatment that is unique to that strata or group of patients. The second is obviously aiming for the MRD negativity. We know that patients who are even high risk, if they get to be MRD negative, their outcomes improve. And this has been shown in multiple different studies. And the deeper the response, better the outcome is. The second aspect is not just getting to be MRD negative, but staying in MRD negative. And that's where the 2-drug maintenance therapy often plays an important role. Because patients who get to be MRD negative and lose the MRD negativity quickly tend to have actually worse outcome than people who don't even get MRD negativity. So we have to get there and we have to stay there. Now the question is, is the one way to do that by giving patients treatment until progression? I think there are studies looking at early discontinuation. There are, I think, mounting evidence that we can discontinue therapy in standard risk patients, especially if we can get deep response. But I think the the data on high-risk patients still lagging at this point in time. And then finally, age and performance status is another way to adopt or adapt therapy. And this is relatively old paper, but highlights the concept of how we can give the same medications, but maybe decrease the dose of the same so that we can actually get the benefit of the combination therapy without subjecting patients to undue toxicity. So, where we want to be is for the precision medicine. The question is, how can we get there? And what is the data to support it? So one of them is, the data that we have from venetoclax. So the venetoclax is a BCL2 inhibitor. We know that it can be used in combination with dexamethasone or the standard of care therapy in patients with 11-14 translocation. And in these patients, it seems to really impact the outcome and get really deep responses. And so that is one thing to be considered, but only in the patients with 11-14 translocation. Can we target the other abnormalities that we see, like 414 translocation? We know that the 414 translocation leads to, again, upregulation of MMZ. So we are looking at some drugs, novel therapies in the clinic that targets MMZ. And this appears to be promising early data, so we don't know yet. Now, other abnormalities like P53 deletion. So, we all have two copies. So one is lost, we still have one. So can we make it more active by giving drugs like nutlins, for example? We did a study of idasanutlin. We really did not see much of a benefit in that late line setting, but there are ongoing studies trying to see if there are other ways to make the remaining P53 gene to be more active. Now, we also know there are other mutations that can drive disease, especially in the extramedullary disease. We and others have shown that the presence of KRAS and NRAS mutations are pretty high. Here's an example of a patient with BRAF mutation. Again, all these tends to upregulate the MEK pathway. And here you can see that a patient with extramedullary disease with their BRAF mutation being treated with vemurafenib, and you can see that the disease responds well, and the light chains actually, or the M spike actually comes down. So there have been another study looking at trametinib in various combinations, and they have shown again some responses in these patients. It's really hard to tease apart what happens in with one drug when you give it in combination. We have done a window of opportunity study for patients with RAS mutations, treating them with a MEK inhibitor, and have shown that the clone that carries the RAS mutations do respond, but given that this is subclonal, the remaining clone continues to grow, highlighting the challenges that we face with using targeted therapy in these patients. This is another trial called the Burma trial that combined a BRAF inhibitor and a MEK inhibitor, and they did see responses in quite a few patients. Again, early data, small patients, set of patients. This is a study that we did called My Drug study. This is no longer running, but we tried to genomically characterize tumors at baseline, and based on the predominant mutations, treat them with a targeted agent given for a couple of cycles and then combined with a standard of care, ixazomib, pomalidomide, dexamethasone. It's concept. We did learn some biology, but not necessarily prove that targeted therapy is good for patients with myeloma yet. The question then is, why do patients, when they relapse, what happens within the genomic makeup? What we know from multiple studies is that a lot of these subclones are present at baseline, and they tend to wax and wane depending upon the treatments we give for these patients. So targeting just one clone is probably insufficient. So we had to figure out how best to target multiple clones. And that's where some of these, either using broadly active therapies like immunotherapies or combining them with targeted agents, will probably play a role. So again, I think just to conclude, there's certainly a very heterogeneous disease. It's important for us to prognosticate patients at baseline based on all the known data, but also continuing to keep an eye on how the disease behaves on the face of therapy, which tells us what to expect in the future. And to some extent, we can individualize therapy, and hopefully in the future, depending upon the set of abnormalities they have, we can probably give them some unique combinations, but also taking into account some of the host factors like frailty and age. And hopefully that will lead to even better outcomes than what we have currently with the treatments we have. Stop there, and happy to take any questions.
Thank you. So wonderful talk, and you covered most of the questions we have, but still a long list of questions. So before I ask the list of questions which I asked on various social media platforms, if anybody has any questions, they can put up in the chat box, or they can take up directly with the sir. I'll start with the first one. So we received this question that where do you place the role of tandem transplant in 2026 and the role of allogenic BMT in myeloma?
So, again, there's not a broad role for me either of these modalities, but you always have to take in the context of where the patient is being treated, right? So, I think if you have high risk disease and you're in a context where you don't have access to any of the immunotherapies, I think it's fairly reasonable to think about a tandem auto transplant, especially if you don't get a deep response with the first transplant. So I think that would be perfectly reasonable. Nobody can fault you for doing a tandem transplant in that patient. But if you have access to some of the newer therapies, it is unclear whether the tandem really contributes something. Allogeneic transplant is a tough question because, again, none of the phase 3 trials have really shown benefit, but we all have patients in our practice who have done well with allogeneic stem cell transplant. So where do I think of allogeneic transplant? If I see a 35-year-old patient who has a 17p deletion and a 414 translocation, and I give him the standard of care quadruplet, a single auto transplant, and he's relapsing year out from his initial therapy, that this patient actually has proven to be functionally high risk, not just based on the baseline setting. I would definitely have the discussion with that person about doing an allogeneic stem cell transplant. Obviously, with all the immunotherapies and CAR T, it's often difficult to jump into something like allogenic before we try those things. But also with allogenic transplant, we know that if we wait till the last therapy, it's probably not going to be of any benefit. So there is a shared decision-making process that needs to happen after the first couple lines of therapy if the patients are continuing to behave, the disease continuing to behave badly.
Right. Thank you, sir. So another one which I got was what is the right approach to manage plasma cell leukemia at the time of diagnosis and also at the time of relapse?
Yeah, so I think the two key concepts about plasma cell leukemia, the first thing is to get a rapid tumor reduction, right? So I think that's where the conventional chemotherapy combinations like DPACE or DSEP type regimens can have a role still, so that we can debulk this. So again, it all depends on the clinical presentation. If you have circulating plasma cells, normal blood counts, not a huge tumor burden, maybe we can forego this step. But often patients present with significant cytopenias, packed marrow, significant circulating cells, and often extramedullary disease. So I think debulking with a couple cycles of DSEP was quite helpful. In the upfront setting, I would do something like that and then give them, if need be, and then otherwise start them on a DRVD or a DKRD kind of regimen, 4 cycles, auto transplant, and then a 2-drug maintenance therapy. In the relapse setting, I think we should certainly consider using either a bispecific combination like Tectal. Again, use them after you debulk them. If you have access to CAR T, you can certainly consider CAR T, but in the plasma cell leukemia setting, you cannot do CAR T and then not give any maintenance therapy. So one has to really weigh the benefit of, do we do a CAR T or do we just go ahead and do a bispecific combination? I don't think we really know the answer to those questions. One thing to keep in mind, half of the patients with a newly diagnosed plasma cell leukemia do have 11-14 translocation, so there might be a role for using drugs like venetoclax in combination with other therapies.
Right, sir. On the context of plasma cell leukemia, somebody has put up in the chat box. So what is the cutoff of circulating plasma cells to correlate primary plasma cell leukemia and any role of upfront flow in diagnosis?
I
Yeah, so I
have
think
the same question, sir, because in relapse setting, if there is more than 5% of blast in the peripheral blood, we call it as relapse and we will treat morphologically. But if, especially in plasma cell leukemia, when we are getting 2 to 3% of plasma cells, which are blastic, so will you wait or will you treat? How you proceed with that? I am
So it depends on
curious.
the treatment context of the patients, right? So yeah, I don't, the 5% is the cutoff. That is part of the IMWG recommendation for calling somebody plasma cell leukemia. But treatment decision is not based on that. Treatment decision is based on the disease status. You treat patients who relapse myeloma with or without plasma cell leukemia. So in order to decide whether somebody needs treatment, there's no cutoff. It all depends on the clinical context. If somebody is progressing, I would think somebody with 3% plasma cells in the circulation is probably somebody with active disease that needs therapy. Flow cytometry cutoffs have been used. For example, 1.2% has been shown in some other studies as having an outcomes that is equivalent to the current IMWG definition. But the thing to keep in mind is plasma cell leukemia is a terminology that was developed a while ago before we had all these sensitive detection techniques. It is a spectrum. 2% is worse than 1, 3 is worse than 2, 4 is worse than 3. So I don't typically, I just think about any circulating plasma cell as being a high-risk disease. The more you have, the worse it is.
All right. So again, on the context of plasma cell leukemia, another question in the chat box by Dr. John. So he's asked if DCP is always required, or can we just start with upfront quadruple in cases of plasma?
Absolutely. So it all depends on what the, if the patient presents with really bulky disease and significant cytopenias, it might be easier to give them a cycle or two of chemotherapy because they often tend to respond nicely to these. But if somebody comes in with plasma cell leukemias, counts are fine, no other, urgent issues, then I think we can certainly consider just going straight away to a quadruplet.
All right, sir. So another question which I've received from a lot of people is on teclistamab. 3 things regarding teclistamab. Right spacing, because the cost is a major issue over here. Second, reuse of the vial once opened. And third, the concept of drug holiday or TFR in patients who have stringent CR MRD negative with teclistamab.
Yeah, no, I think, with the bispecific antibody, we are still kind of learning how best to space them out. If somebody has, I think most of us tend to use a response adapted therapy. If the patient gets into a deep response, we often switch over to, once a month a regimen with most of the bispecifics. So starting off weekly with teclistamab or every other week with talquetamab, and then kind of doubling that interval once the patients respond, maybe VGPR or CR would be a very reasonable thing to do. The thing to keep in mind is the longer the underlying risk, or the higher the underlying risk, the longer you want to have that deep response in place before you start reducing the dose. And again, it's a balance between what the patients can tolerate versus what what you can actually be able to do.
Right, so thank you, sir. So elrantamab has recently entered the Indian market space just a week back or so. So any preference of right patient for elrantamab versus teclistamab, or any advantage of one over the other?
Really, no. I mean, none of them have been studied head to head. If you look at the data, they all seem to have about a 60 to 70% response rate. So I think, especially in the Indian setting, I would just go with whatever is the least expensive out of those.
Right, sir. Sir, another question, sir, which I've received is, do all the biochemical relapse need treatment, or there are patients you are still comfortable watching closely? Anything with the high risk biology, rapid kinetics, or a trend? How do we go about the biochemical relapse?
So with biochemical relapse, a good question. So, biochemical relapse, we still don't have the right answer as to what is the best time to start treatment in a given patient. I think it's probably to some extent patient dependent. So in my practice, what I do is if somebody has standard risk disease, I tend to watch them for a little bit to get a sense of the trend. If they have high risk disease, I start them on treatment as soon as the biochemical progression happens.
All right. The one is the role of MRD in our resource constrained settings, and which time point does it truly add value, and day
So
100 MRD role.
yeah,
First,
no, I would generally say, it's just a general principle in medicine, right? The right time to do a test is when you're going to do something about the result that you
yes.
get. So it all depends on, are you going to increase the therapy in a high-risk patient after the injection treatment? Are you going to decrease or stop treatment in another patient after, 2 or 3 years of maintenance? So depending on the clinical context, if you think that MRD negative result will, or MRD positive result will make you change treatment. So the two common things are escalating therapy in a high-risk patient or de-escalating therapy in a standard risk patient.
All right, sir. So one more question which I received was the role of radiotherapy, and where do you place it today, especially in extramedullary disease, as a symptom control, as a debulking bridge, or as a part of true disease control?
I'm sorry, can you repeat that?
The role of radiotherapy, especially in the extramedullary
Radiation. Sorry,
disease.
yeah.
Yes.
So radiation typically has very limited role in myeloma at this point with all the treatments we have available. So one is neurological compromise, right? So that's very easy. The second is obviously any patient who has significant symptom due to disease bulk that is time sensitive, whether it's let's say ureteral obstruction causing kidney failure, neurological compromise, as we said. Those are all situations where I think radiation therapy would, or significant pain that is debilitating. In general, if something isn't super urgent, you want to try and see if the systemic therapy can control the disease and symptoms before we jump into using radiation therapy. In the relapse setting, that may be harder because patients may not have too many therapies that they may be still sensitive to. I think in those settings, radiation is perfectly fine. Things to keep in mind: make sure you don't radiate extensive amount of marrow, especially radiation that involves the pelvis and spine. Should be, you have to think about that in a patient who is newly diagnosed in whom you're thinking about stem cell transplant.
Right, sir. Sir, Dr. Aritra has put up a case in the chat box in a transplant ineligible relapsed refractory multiple myeloma after 4 lines of treatment who presented with an extramedullary involvement. They've started the patient on teclistamab. They want your opinion on what should be planned next if the patient does not respond, especially in the Indian context. And second, on the use of the tocilizumab prior to teclistamab.
Yeah, so I think somebody with extramedullary involvement, looks like this patient's already started on teclistamab. So I think if they don't respond, you can certainly try talquetamab. You can try the combination. Certainly CAR T if it's available. Certainly something you can be considered. In general, I think with extramedullary disease, my approach is try to give them often a cycle of chemo to debulk the disease a little bit, and then give the bispecific antibodies. They tend to work a little bit better in that setting. In terms of tocilizumab, it's very practice specific. We don't use tocilizumab prophylactically because we can watch those patients pretty closely in the outpatient setting. If that is not feasible, then I think tocilizumab is perfectly fine to do.
All right. So another case in the chat box by Dr. Shiruk, early relapse in a triple class exposed multiple myeloma. How do you sequence the therapy, including belantamab, teclistamab, elrantamab, or CAR-T?
Yeah, so in our practice, such a patient who's often considered to be a functional high-risk patient would get a CAR-T first as a choice. If they cannot get a CAR-T, then we'll use one of the BCMA-targeted bispecific antibody, teclistamab, linvoseltamab, or elrantamab. Any of them would be fine. We don't often use belantamab mafodotin in that first relapse setting, but in the subsequent setting, even in patients who've been exposed to some of these T-cell redirection therapy, I think belantamab in combination would be of use.
So Dr. Swapnil has asked in the chat box, what is the first line approach of yours to extramedullary disease in resource constrained settings?
Yeah, so I think it has to be, again, a combination approach. I think extramedullary disease, if you have limited, you just have to see the best therapy that you have available that can be leveraged, right? So I think traditional chemotherapy combination for initial debulking followed by the best combination that you can put together. I don't think there's one recipe that is going to be helpful.
Right. Sir, question from Dr. Rachit. What is the preferred bone protective agent in myeloma patients with nephropathy? Pamidronate versus denosumab.
We generally tend to use pamidronate in the setting of renal insufficiency.
Right. Sir, another question on the management of CNS myeloma or CNS relapse in myeloma. So what are the essential treatment pillars? Systemic therapy versus intrathecal versus radiotherapy, or a combination of all three?
Yeah, no, I don't think it's necessarily one versus the other. The question is, again, in the context, I would, intrathecal therapy to clear the CSF, I think it's a reasonable approach. The question is, that's just temporizing measure, and you need to use that in combination with something else. That something else depends on what they have been exposed to in the past. There's obviously plenty of anecdotal data, even with some of the newer immunotherapies, the bispecifics and CAR-T, where these patients have responded very well. So that certainly would be a consideration. If you don't have access to that, obviously the pomalidomide immunomodulatory drug do get into the CSF well. So does daratumumab. So an anti-CD38 monoclonal antibody with pomalidomide would be reasonable. There's some scattered data with use of temozolomide type drugs, which are, again, alkylating agents that can get into the CSF very well. You can potentially combine that with some of the IMiD PI type medications. But again, these are all kind of anecdotal reports. But the key thing is, you have to give systemic therapy that often, that will get into the CSF. The craniospinal radiation is something that you have to really think about it, because yes, it can be effective, and certainly we do use some of it, but it also leads to significant neurological, cognitive difficulties. So it might be something that has to be taken in the context of what is the anticipated survival of somebody. So if you have a 55-year-old person who relapses after the first line therapy with CNS disease, I would be still worried about using craniospinal radiation. Whereas if you have, somebody who is on the sixth line of therapy, very little treatment options left at that point, I think it's a reasonable thing to, from a purely palliative standpoint.
Thank you, sir. The questions on CAR-T, 3-4 questions we got on CAR-T was, one was CAR-T versus bispecific, which is a long and never-ending debate, at early relapse or early triple-class refractory disease. Another one on management, post-CAR-T relapse. Third on cell versus ID cell.
Yeah, so in terms of the early use of CAR-T, as I mentioned before, I think people who relapse early, I think that is kind of a preferred therapy, but we often do give them some maintenance after the CAR-T, because these are functional high-risk patients, so probably not going to be controlled long-term with CAR-T alone. In terms of the cilta-cel versus ide-cel, obviously there's no head-to-head study. Patient populations are different. But in general, we have been using primarily cilta-cel, except somebody who is quite frail and old, where we might consider using ide-cel. I'm sorry, what is the second question?
You covered all of this. Post-CAR-T relapse, CAR-T versus
post-CAR-T relapse. So it depends on what they have seen before. So, you just go with whatever combinations that you can come up with that the patients have not seen so far.
Another question, actually, we also see in clinics, and I've got that question. So dialysis dependent patient, can we take them for autologous VMT or not?
Absolutely. I think we do, regularly do autologous stem cell transplant in somebody who's on dialysis. In fact, it's easier to do it on dialysis than somebody whose renal function is very borderline, because sometimes taking them to the stem cell transplant can push them over the edge and may, in fact, have them go into needing dialysis. But yeah, for dialysis, it's fairly straightforward. We condition them with 140 of melphalan, and then the rest, everything else is exactly the same. And there are patients who might get off dialysis. We have seen some people getting off dialysis even as much as a year out from their transplant after, good disease control.
Anything extra we need to do for those patients who are at that borderline creatinine?
Just very close management with fluid management, and sometimes these patients might end up needing, maybe 2 or 3 sessions of dialysis to kind of tide them over some acute events during the transplant. But it's just close collaboration with the nephrologist in managing them.
So I've got question in the chat box by Dr. Ramaswamy on high risk and non-high risk only. Is it that is only the category, or there's an intermediate risk category as well?
We don't have an intermediate risk category at this time, because the IMWG risk score is just trying to identify the best defined set of people with poor outcomes so that we can design clinical trials around them. Now, if you look at the other 75% whom we're calling not high risk, that's going to be a spectrum. So somebody could have a 1Q abnormality versus somebody who doesn't have a 1Q abnormality. Certainly the risk is going to be higher for them. So I would say if you want to use the intermediate versus standard risk, anybody with a singular high risk abnormality, I would put them in the intermediate risk.
All right. Sir, another question in the chat box. Where do you place the role of cell mods in the current era, and is it coming up in a big way or not?
Yeah, I mean, there's, the phase 3 trials that have been at least reported to be positive. So I think that will get approved eventually. It certainly seems to be quite effective. Will it replace IMiDs? It's hard to know, because again, it depends on the setting, right? So especially in a setting where you can get lenalidomide and pomalidomide generic, the incremental benefit of CELMoD over those for the difference in the cost has to be factored into the practice.
2, 3 more questions I've got. I don't know how many we are able to. So by Dr. Aritra, in what case scenarios, apart from old age, would you like to modify the dose of melphalan during conditioning, during the autologous VMT?
So the only place currently where I would reduce the dose is in the presence of renal insufficiency. If the person is too old to need a dose modification. One could argue that you probably don't need to do a transplant. You might as well try and give them a triplet therapy like Imros or Cephas-Trab. If you don't have access to an anti-CD38, I think it's perfectly fine because, again, there's European data showing that if patients between 65 and 70, if you dose modify or dose reduce melphalan, transplant versus not transplant, it's unclear how much the advantage is.
Right. So again, on melphalan dosing, another question in the chat box. What about the dosing strategy for obese patients?
So we will use an adjusted ideal body weight. So
Yeah.
I think with that, you should be fine.
Right. Sir, one question from Dr. Paritoshkar. Can we get off maintenance in standard risk myeloma who has sustained MRD negative or not?
Absolutely. I think most of the data point towards a standard risk patient. If they're MRD negative, sustained for 2 years, we probably can. And even without an MRD test, maybe you can, maybe you don't need to give them lenalidomide for more than 2 years.
Right. And another question by Dr. John. Sir, how often do you see acute toxicity with carfilzomib? And are you using ejection fraction or global longitudinal scale to consider a patient fit for carfil or not?
We do baseline echocardiogram in these patients. I think it's a reasonable thing and the safe thing to do. It's probably, in the initial, as a newly diagnosed myeloma setting, we probably see about 2% maybe, 2 to 3%, depending upon how well you draw the line for what you define as cardiotoxicity. We do see elevations in NT-proBNP probably more often. So we don't necessarily, we do a baseline CT, a baseline echocardiogram, and then make a decision whether somebody has significant cardiac comorbidity and whether we should be using carfilzomib.
I think most of the questions are done for the day. Thank you for answering them so patiently and nicely. 2 things before we end. So first, cure in myeloma, have we reached it or not? Second, sir, your take-home message from today's talk.
Yeah, so I think, cure, I think we are definitely to a point where we can hopefully cure more people. I think, what is cure? We recently developed a definition by the IMS, IMWG, which essentially, it's probably it's not perfect, but what we think if somebody can reach MRD negativity 10 to the power of -6, that is sustained for 5 years with at least 3 testing in between, a functional imaging that is negative, and they've been off treatment for 5 years. We think this patient's probably cured. But again, I think there's going to be some nuances to it. So,
your
but I think
take-home
definitely
message.
we are seeing more and more of the cure fraction here.
Right. So today's what message would you like to give the audience from today's?
So I think the key thing is, even though myeloma seems myeloma, it's different for each patient, and you have to really take into consideration disease biology as well as the patient characteristics, the host and tumor. And I think using kind of that granular data to not you may still treat them with a particular combination, but you had to adapt for the individual patient. So if it's an old and frail patient, you may still give them DRVD, but you may give them lower doses. If it's a young fit patient, you might give them a doublet maintenance indefinitely versus if it's standard risk patients, you might give it for 2 years and stop. So there's a lot of adaptations that you have to make at baseline and with ongoing therapy, and you have to continuously see how the disease is behaving. So it's a little bit of a hide and seek game there. So
Thank you very much, sir. Fortunate to have you, and thank you for your time. We had some 300 plus registrations for today, and people joined all across Southeast Asia. Lovely talking to you. Thank you very much,
thank you,
sir.
Mahek. Yeah, thank you. Take care. Bye.
Bye, sir.